Good evening, friends. This is an X-ray of a 45-year-old female who presented with bilateral knee pain due to medial compartment osteoarthritis. The duration of pain was 2 years, which was not getting better. She had an injection of steroid followed by hyaluronic acid that didn't help. As you can see on this X-ray, there is a definite decrease in the medial joint space on both sides, right side more than the left. And the long leg X-ray also confirmed that she has a varus malalignment of both the knees. So she was offered medial open wedge high tibial osteotomy, and I will show you how I do medial open wedge high tibial osteotomy without using any metal implant. This is a very simple and unique procedure which can be done in patients up to 15 degrees of varus malalignment. You can see there is definite decrease in medial joint space. You mark the landmarks around the knee as I have shown you, and you make a longitudinal incision on the medial side to the patellar tendon. And once you expose the subperiosteal space, then you put a drill bit pointing towards the head of the fibula, as shown here, and then you are ready to make a cut helping the saw. So you make a clean cut just parallel to your guide, that is your drill bit. These are the instruments that you use for making high tibial osteotomy, which are basically very fine osteotomes, and the template to gauge the width of the osteotomy. You can see now my first osteotome is going inside, and gradually you spread the osteotomy site with the help of osteotome and the templates, the metal templates that you have, as you can see here, until you opens up sufficiently as you have planned before. So suppose you wanted to correct 7 degrees varus malalignment, then you put 7 to 8 mm of a wedge, which is made up of tricalcium phosphate, TCP. It is available. They come from 6 mm to 15 mm size, and the size, they are triangular in size. The medial side is broad than the lateral side, as you would expect, because it's an open wedge osteotomy based on the medial side. So once you have done unicorticotomy, you do not have to breach the lateral cortex. You must try to maintain the lateral cortex, because if you breach it, then this osteotomy is a failure, and then you have to use a metal plate to fix it. So once you have opened the gap, the osteotomy, and checked it on the image intensifier, then you put the tricalcium wedge phosphate, TCP wedge phosphate, and impact it gently with a plastic impactor that is available. It goes very easily, and it stays there. You again check it on the image intensifier. It stays. You can move the knee very well, and it doesn't go anywhere. It is always kept under compression because of the varus deformity. Because of the varus deformity, there is always a tendency to have compression on the medial side, so it stays. The post-operative treatment for this patient would be 2 weeks immobilization in a knee immobilizer, followed by knee flexion, static and straight leg raising test exercises, and At 4 to 6 weeks, the patient is allowed partial weight bearing, which is gradually increased. And by 2 to 3 months, most of the patients are able to take full load on this without using any metal implant like plates, Pudu plates, or the AO type plates. You can be quite successful in achieving a good osteotomy, which heals very nicely, and the post-op protocol is also not changed. There is an apprehension that these TCP wedge may fracture or may slip out, which never happens. They are stable enough. The only caveat to this type of osteotomy is that you cannot correct a large degree of deformity correction, more than 15 degrees, and you cannot rely on these TCP wedges only. But my take on this is that you should not do high tibial osteotomy for osteoarthritis in severe varus deformity of more than 15 degrees. Hence, this simple solution is good enough for most patients. It obviates the need of using any metal implant which needs to be removed. It becomes more expensive. There are more chances of infection and complications. And this procedure only takes about 15 to 20 minutes, and it can be done through a very small intromedial incision, which is usually in the line of your future incision for total knee replacement. So I would recommend that uh, you people can try this osteotomy, and it is quite a successful and very simple surgery to do. Thank you.